I hope you had a chance to look at Mark's illustrious bio. Dr. Nunnally is an accomplished critical care physician, physician leader, as well as anesthesiologist. He comes to us from New York, where he is the director of all the adult critical care units. He has, in the past 6.5 years, he has revamped the system to make it a smooth, well-oiled machine. He is a beer and wine aficionado. And with that, I will introduce him. The first thing we're going to do today is we're going to let Dr. Brian Bateman, our chair, introduce our CA1s. And we're going to do this in 3 sessions. Today will be the first 10, and then we'll have 2 other sessions during our 2 other live sessions. 2 things. If you've seen the QR code, please use that. We're going to use that to track attendance. And there is food coming. It'll be here between 7 and 7:15. We're trying to discourage people from eating and drinking in the room. So it's going to be a grab and go style. So fingers crossed. With that, take it away. Thank you.
Okay, thank you, Sheila. Welcome, Mark. So I thought we'd use this opportunity of all of us being together to introduce our new CA1 class to the department. So if you're here, when your slide comes up, if you can stand up. So first up is David Chen. Yeah. So David's hometown is Toronto. He went to med school at UVA, intern year at UCSF in PEDS. His backup dream job is to be a ski guide. And his OR playlist is Jesse E. Joy. Jesse E. Joy. All right. Our next new CA1, Sarah. Are you here? Okay. Well, welcome, Sarah. Maybe she's on Zoom. She comes to us from Boise, Idaho, med school at University of Washington, intern year at the University of Washington in surgery. Her backup dream job is to be a professional dancer, and her OR playlist is 90s hip hop, R&B, WizKid, or Latin hip hop. So welcome, Sarah. Danica, are you here? All right. Danica's from Florida, went to New York Medical College, intern year at Stanford. Her backup dream job is to be a food critic, a great choice. And her OR playlist is Afrobeats and Komba. Ali. All right. Ali Frankel is Californian from Santa Barbara, med school at UCSD, intern year at Santa Clara Valley. Her backup dream job is to be a National Geographic photographer, and her OR playlist is SC. Okay, all right. I'm getting lots of ideas for my Spotify playlist. All right, Sydney. All right, Sydney here. All right, welcome, Sydney. From Houston, Texas, med school here at Stanford, intern year at UCSD. Her backup dream job is to be a yacht hand or an alpine guide. Nice choices. And her OR playlist is Zach Bryant or Leon Bridges. All right, Brenna. Brenna's from just down the road, Los Gatos, med school at Harvard. I've heard of it. Intern year, Kaiser Oakland. Backup dream job to be a golf pro, and her OR playlist is Queen or classic rock. I think that would be my OR playlist. Roberta. All right. Welcome, Roberta, from a Floridian, from another Floridian, from Gulf Breeze, Florida, med school at UCLA, intern year at UCLA Olive View, backup dream job party planner, and OR playlist Harry Styles. All right, Mohan. All right, another Floridian. We have a lot of Floridians. Med school at Northwestern, intern year at St. Vincent's, Indianapolis. His backup dream job is to be an economist or a social entrepreneur. A little more hardcore than yacht hand, but good choices. And OR playlist is Park Hangs. Jordan. All right. Jordan is from New Jersey, med school at LSU, intern year at Ochsner. Her backup dream job is to be a wildlife conservation biologist. Her OR playlist is 90s hits and classic rock. And then finally, Will Yang. His hometown is Ellicott City, Maryland, med school at Zucker School of Medicine, intern year at Santa Clara Valley, backup dream job to be a poker player, and his OR playlist is country music. Ask the schedulers not to assign me to work with Will. All right. So now turn it over to Mark.
Thank you, Dr. Bateman. One other housekeeping issue. If all the people on Zoom, if you have questions for Dr. Nunnally, please send them via email to me. That way we can monitor them. And for Dr. Yang, we'll make sure he works with Dr. Anson Lee, who also loves country music. So thank you.
Great. Can everyone hear me in the room okay? Excellent. So this will be a lecture about thinking, because actually, frankly, we think for a living. And you see the title, Thinking Fast, Thinking Slow. Some of you may be familiar with the book Thinking Fast and Slow, which is the backbone of this lecture. But I wanted to apply this to clinical medicine and maybe give you some ideas about how we might think about things. Now, I've been asked to put this text your attendance in. We're in a new era. You are being watched. Be sure to text in. I have nothing to disclose. If I did, I may not be here today, but hopefully you'll enjoy the presentation. I want you to have more of a realization about which of your biases may be helpful and which of them might be harmful. We all have biases. I hope I can convince you of that by the end of the lecture. I want you to examine some of your own decisions and think about the influence of fast and slow thinking on them. And I want you to plan your decisions with consideration about how things may unfold. Again, this is about thinking. Hopefully this will make a lot of sense as we move along. To introduce the backbone, Daniel Kahneman is the author of Thinking Fast and Slow. And the premise of the book, if you haven't read it, is that there's two systems in which we think. There's a fast system that's fairly quick and intuitive. There's a slower, more deliberative system. And at times, it's really important to separate these two to understand how it is we arrive at decisions, especially in a difficult place. The two systems are indeed complementary. So I'll start out talking about the fast system, some of its advantages, some of its disadvantages. I'll move on to the slow system, and I'll try to put this all together within a medical milieu. The first place to start is where we are today. We're in a place that's a high-stakes environment. Time is a very valuable resource. There are many demands, and the risk of an adverse outcome is proportionally higher than many other places. In other words, if things go terribly bad in our world, it's a really, really bad day. Within that, we face all sorts of trade-offs, all sorts of competing demands. And for those of you that are new to training, welcome to the rest of your life. You'll be in an OR cramped to the full cognitively with tasks and demands and interruptions and things are going on. And where's my laryngoscope? It's time to intubate. Is the sort of situation you may find yourself in. I'm going to take this a step further and step back and make it a little bit more abstract, quoting my colleague, Richard Cook, talking about a social definition of safety, because a lot of what we do is predicated on safety, getting good outcomes and keeping patients out of peril. But defining that environment is a little bit difficult. So let me try this out. This is from Rasmussen and Cook. And the idea is that we work within a space of possibilities. At one edge of this space is a boundary. That boundary is economic failure. You can only invest so many resources. You only have so much to invest. There's time resources too, but at this point, it's important to know you got to be able to pay for what you can do, and there's only so much you can do with the resources you have. There's another boundary, which is unacceptable workload. We can only do so much at a time. We can become very efficient, so we can push that boundary, but in the end, there's only so much you can do. And that's important with regards to attention as well. And then finally, there's another boundary, which is the acceptable state of affairs. You cross this boundary, bad things happen. The patient goes into cardiac arrest, something terrible occurs. This is where accidents are. We typically don't know exactly where this boundary is. It's like the thin ice on a lake. But what we'll do is we'll draw a boundary upstream from it. It is our margin of safety. And this is a cultural definition of safety. So we understand that crossing this predetermined boundary helps us to understand where we think we can avoid failures. Failures lie somewhere beyond it, but we don't know exactly where. And of course, that defines our space of possibilities. There's a pressure for maximal efficiency, that is, use your resources the most. That pushes you away from the boundary of economic failure, but towards that boundary of safety. There's another gradient pushing you in the other direction. If I go forward, I can show it to you. And that's the migration towards least effort. It's not that we're lazy, it's that we're trying to use our resources and our attention appropriately. And that, of course, pushes us away from unacceptable workload because we're getting more efficient, but it pushes us towards that boundary of unacceptable affairs. This is where I want you to think about cognition, because you can only invest so much cognitive coin over the course of a day, and you have to invest it wisely. We live within the environment. There's natural Brownian movement. Things occur that are out of our control that can sometimes move us closer to the edge. And of course, if we cross the edge, that's where accidents occur. So that's the high stakes environment I want you to think about when we talk about thinking, because thinking is an important process. It's this concept of coding, storage, and retrieval. People over the centuries have tried to describe the mind several different ways. They've tried to describe it like a machine, like a steam engine in this case. You can tell what era this came out of. But it's not a machine. It doesn't act mechanically. People have described it as a card catalog, a repository of vast amounts of information, but that's not completely true either, because a card catalog is agnostic to the prioritization of the information. And moreover, we don't save every bit of data that we experience in our lives. We select what we remember, and sometimes we don't even remember accurately. What the mind is a relational instrument. There's subconscious and conscious activities. And if you think about subconscious and conscious in terms of system 1 and system 2, you get an introduction into how these two systems perform. Intuition, nothing more or less than recognition. So if you see something, makes the hair on the back of your head stand up, it's likely you're relating it to something in your past. All right. So there's cognition stages. We'll spend a little bit more time on this when we talk about definitions of slips, errors. But what you need to know is that you formulate what you want to do, you recognize things, and then you decide what you're going to do, frequently within milliseconds. You execute that, and then you monitor to make sure it works. Writ more largely, you can think about the way you would manage a complex problem in several different ways. There's sort of the rational approach, which is you're seeing something completely novel, a complex math problem, for example. You're going to have to pay direct attention to make that work. That's the thinking slow system, number 2. You can be trained to do something where you have a combination of fast and slow. They work in a complementary manner. Maybe you go to a code and you use ACLS. You've been trained to use ACLS. You know the rules, you know the algorithms, so you can move through them somewhat intuitively, but at the same time, you're always checking back. You're always checking your differential diagnosis. And that's more of a rule-based thought process. And then finally, if you get really good at something, it just becomes routine. This is where the experts at Airway, this is where expert athletes, they live here. Chess grandmasters live here. They don't need time to make decisions. They can read a chessboard and tell you what's going to happen in 3 plays. But it takes a long time to develop that level of expertise. That's system 1, but that's system 1 refined. All right, so experts do things almost automatically. They're faster, they're more efficient. They work better in that high-pressured workspace. And they work with their 2 systems that are complementary and critical. But in this case, it's system 1 that really helps them to be efficient and focus their energies where they need to go. If you're just starting out, learn the sequence. Intubate, auscultate for breath sounds, look for end-tidal CO2, turn on the vent, turn on the vapor. Repeat, repeat, repeat. How many CA1s will forget some one of these steps? Everyone. I did it dozens of times until you get it down by rote memory. That's training yourself to think fast. You can save the cognitive energy that you eventually get from doing this almost reflexively to paying attention to other important things. Few definitions. If you break down cognition, you can actually see where things go awry. I'll skip, trip, or stumble, but if you intend to do something, but you deviate from it, that's called a slip or a lapse. If you apply the wrong rule or you make the wrong diagnosis, we can call that a mistake. And straying from the path of righteousness is beyond this lecture. Talking a little bit more about this concept of error, because I'm going to throw these words around: failure, mistakes, accident, error. The problem with error is its process of social attribution. Again, I'm quoting my colleague, Richard Cook. But what you have to remember is judgments are usually made based on the outcome. What's important to distinguish here is we think about accidents after they occur. We judge them by their outcome. So we already are dealing with a biased sample. I am not aware of any study in medicine that looks prospectively at human cognition, looking at people in situations and dissecting how they're going to think about them, observing them, and seeing what happens. That's problematic because it means that we have a very biased or skewed judgment on how we make mistakes. And what that leads to in a high-stakes environment, where there are often other stakeholders, is Massioli's first law of life, which, if you haven't ever seen it, you'll see it here first. The search for someone to blame is always successful and is the only job always completed on time, under budget, and with 100% success. So we talked a little bit about cognition. I've hopefully placed a nice context for stakes. And we've talked somewhat about some of the trade-offs that we might observe. going back to these formulations of different ways to go astray, different sources of so-called error. Let's dissect a couple of them. A slip is a nice one because we all encounter slips. And slip is a situation where your system one is fairly well trained to do something that gets tripped up. And you do something without thinking about it. This is the classic. I get up on Saturday morning to drive to the store in the morning. I get in my car, I start driving, and I end up at work. Or in this case, I got up early to make myself a cup of coffee. And you see, I brewed myself a perfectly nice hot kettle of water. A mistake is where you don't apply a rule or you're not using the right set of knowledge. Again, I said, you like using the wrong rule to do something, you're in the wrong part of the ACLS algorithm, or maybe you make the wrong diagnosis. You're a pressured provider in an emergency department. You have a patient that has a high respiratory rate and tachycardia. You see this infiltrate on a chest x-ray and you say, aha, this patient's got pneumonia, this patient's got sepsis, and sepsis means we need to give 30 milliliters per kilogram of IV fluids. Let's get those in. And then you discover that with more time, the patient actually gets worse. And now you've got 4-quadrant whiteout, and you do a little more diagnostics and you realize that they're heart failure from a mitral regurgitation. And of course, you've made the wrong diagnosis. That's a mistake. Happens all the time, especially under pressure. But that's an example of our cognition going awry. A lot of system one in there, not a lot of system two, but you see what went wrong. So one thing to think about is that our world is not homogeneous. Look at the traffic grid. We can drive almost reflexively most of the time, but there are places, there are pinch points where there's higher risk than others. There used to be this on-ramp in Chicago, right in downtown Chicago, where you come in, really short entry, right onto a major freeway with trucks barreling down at about 70 miles per hour. That's a high risk point. Traffic accidents are not distributed evenly because risk is not distributed equally. I'm going to take a moment and talk about communication. Because we talk about communication a lot, but we don't necessarily get at what communication is. It's a leading factor in accident investigations, and that's 100% true. But the question is, why is that? One is that there's always more that could be said. And I would argue that system one, which is almost reflexive and allows us to do things expertly, also means that we're not really savvy at talking about what makes system one work or why we're good at something. So sometimes what is unsaid is actually the expertise, but that also leads to situations where not everybody involved in an exchange may know what's going on. There's cognitive dissonance. That can be problematic. Two different people have a different mental model of a situation. That, by definition, will lead to a communication problem. It will be attributed to communication because those people didn't come under the same concept. Retrospection is also important. We're very good at looking back at something and aligning history to suit our purposes. In this case, if there's any cognitive dissonance, that means it will have disparate ideas and will point a finger at communication. And of course, communication burdens are held disproportionately at the sharp end. That's where we all work, where the pressures are highest and the trade-offs are greatest. And then remember that we always perceive and remember with bias. I said it earlier, but I'll say it again. We don't remember everything, every detail of everything that we see, and we don't even remember accurately. There are great studies out there where people will have very vivid memories of things that occurred or events, or maybe some figure from their childhood, and they don't remember it accurately. All right, so why should we think fast? Well, it's responsive to time pressure. If you're doing CPR, you don't have a lot of time to ponder the patient. You need to move forward aggressively. In this profession, you resuscitate first, and you figure out what's going on second. When you do procedures, it's important to be efficient. Thinking fast is expertise. It's very efficient, and it paces the day because, again, we only have so much cognitive coin to spend. And we need to spend it wisely. So if we think deliberatively about everything we do, not only are we going to be slow, we're going to be mentally exhausted in a very short period of time. When I originally talked about this, it was actually a pro-con debate. And I would talk about the FAST system and why it's great and why it makes us experts. And then my con, actually Avery Tung, a colleague and actually a former alumnus of this fine program, would talk about going slow. So now I have to make the case for thinking slow, which is important. As I mentioned, the two systems are indeed complementary. So I'll talk about calculations. System one is really bad at math, just as a general rule. So anything that deals with more than a memorized math problem, you're going to be using system two. Doubt and skepticism come from system two, and they're both really, really important. You use system two to train system one. The only way you can become an expert at a really complicated task is to have that system two work to train up system one to be able to do it. And then really important inquiry, both before and after the fact, and knowing how to recognize your own biases and either harness them for good or avoid them when necessary. little bit more to talk about on math. Anyone that's been trained in statistics can understand a couple things very quickly. Statistics are not intuitive, and the people that are really good at statistics tend not to be very good at explaining how they understand statistics. So a good teacher of statistics is worth their weight in gold. And it also to say that you definitely use a lot of system 2 to do statistics well. And even experts at statistics have to step back from their own biases in order to talk about them and solve simple problems. We're not good at recognizing randomness and teasing it away from what is signal in scientific studies. There are numerous studies out there, very small, underpowered, with dramatic results that temporarily changed clinical practice until people did a larger study where those same results simply disappeared. We miss regressions to the mean. Who's familiar with the old so-called SI cover jinx? If you put a team or an athlete on the cover of Sports Illustrated, they're always destined to do poorly. Well, it's very easy to explain in terms of regression to the mean. The reason you get on the cover of SI is because you did something extraordinary. You excelled beyond what other people did. And odds are, if you were performing exceptionally at one point, if I were to bet money, then in the next sequence of events, you're not going to perform as well. That's simply called regression to the mean. You're outperforming yourself. You're going to go back to normal. Doesn't mean that they're jinxed. But System 1 doesn't think that way. System 1 looks at it and says, okay, this person's poor performing. Clinically significant effect sizes is really important. Powering studies is extremely difficult, and most studies are inaccurate, incompletely powered, I should say. And that puts us at risk for a lot of different problems. We don't think intuitively about that. You have to step back and use that slow thinking system. And then rational calculations, importantly, can overcome some of these blind spots, but you have to be aware of when to think about them. Skepticism is really important in medicine. You have to be willing to think about alternative explanations all the time. This is how you produce your differential diagnosis. This is how you question yourself. This is how you keep yourself away from fixation problems, but it requires a lot of effort. System 1 simply cannot incorporate an alternative explanation of reality. System 1 will lock onto something, recognize something, say, this is my pattern, and move forward with it. You need System 2 to step back and say, there are these 2 other possibilities out there, and I need the following information in order to determine whether I'm on the right path or I need to deviate and do something different. It's like looking at that patient with the chest X-ray infiltrate and being willing to entertain an alternative diagnosis. It's intentional, it takes effort, that's System 2. We tend to be overconfident, and we value things by what we remember and what we experience. And that triggers our System 1. So if we're recognizing something, or we think we recognize something, we can be taken down the primrose path of fixation bias. What else? Well, we have to resist those certainties. It's fundamental to science to be a skeptic. You look at the history of skepticism, it's actually a very positive thing. Questions are always harder than answers. And so if you talk to somebody and they're giving you lots of questions, you may be talking to a very wise person indeed. Inquiries do take effort. And so we have to always recognize when to spend that effort appropriately. If you recognize your biases, you can develop social maturity. I will challenge you to think about a few things. Set goals. Goals are important because what they do is they allow you to achieve an endpoint that's very satisfying to you, and you're more likely to remember things positively. Recognize hindsight bias. That is, after an event, you are more likely to say the outcome that occurred would have occurred than you would prospectively. And there are really interesting studies where they give people different scenarios and different endings. And the same scenario and the different ending, the people will say very different things about how they would have imagined the scenario going. Even when they're told that they have this bias, people still reflect it. It's incredibly strong. Go to any M&M conference and you will see hindsight bias. Things to think about. Emotional significance of events actually is coded into our recollections. And so that triggers our System 1. You think about a question like, when do you get pleasure from your car? Daniel Kahneman talked about this. You know, some of us own cars that we're very proud of, but most of the time when we're sitting in our car in traffic, we're not getting a lot of pleasure from the vehicle. But it's when we think about that vehicle and its value to us that it's actually important. The flip side of that are pathologies like depression, which in some respects involve a self-reinforcing cycle of miserable thoughts. If you're constantly putting negative recollections onto things, triggering your System 1, your perspective on the day changes dramatically. And you can imagine that's not a pleasant experience. Emotional maturity comes from creating and understanding values, setting and achieving goals, again, creating a positivity around an experience, finding your own blind spots, and understanding where you're biased and where you might see an event or something bad happen in your world that is actually not quite what it seems. There's always another explanation. And I throw in here this concept of empathy, because medical empathy is about understanding just how much of a challenge your colleagues face on a continuous basis. And when you walk into a situation where a bad event has occurred, one of the first questions you should ask yourself is, how hard was it for each player in this situation in real time to understand what was going on? I'll try to illustrate that more in a little bit. Always remember that system 2 influenced by remembering is system 2, but it's influenced by system 1. The coding and retrieval and the emotional significance directly trigger system 1, but system 2 is responsible for supervising that. So as you frame your day and you think about what you're doing and how you're going to make yourself into a clinical expert, that's the process that's going on. All right, expertise. You become an expert by using system 2 to train system 1. You can see that in things like sports, chess, rescue experts. Experts naturally have a hard time explaining what they do, by the way. It's really hard to sit down with a chess grandmaster and have them say, this is the way I thought about this, because it happens for them in an instant. They can instantly recognize several plays in advance. But you have to use your system 2 to train to that level. And this RPD is something called recognition prime decision making. Again, your system 1 recognizes things from your memory. You're able to code those, pull them out. They become intuitive, and they allow you to make good decisions most of the time, except, of course, when bias plays in. Some examples of expert performance. Buford was a general at the Battle of Gettysburg, and his significant role in that battle was he got there early, recognized the significance of the high ground, and took it for the Union line. And it turns out that ground was critical for the Union to win that war. But that was being able to see into the future, preparing for the future, knowing what will be coming next. That's a seasoned general looking at the landscape. We prepare all the time. We set up our carts, we look at our machines, we check everything out. We do all of these cognitive tasks early in the day so that we can free our minds to do the other things that occur now emergently as we're taking care of patients. Those who do not prepare waste a lot of cognitive energy. Simple things like plugging in the forced air warmer before the case. Why waste your time and energy when it's most needed for other tasks later on? And then planning for contingencies. If the patient develops ventricular tachycardia, what am I going to do? If they become hypoxemic, what am I going to do? In what order? You can train yourself to do this very, very well. That's expert performance. All right, dealing with crisis. The important thing is that you may recognize things, you may prepare really well, and patients may seem to be following exactly what you think should happen, but you should always in the back of your mind keep system 2 running, thinking, what doesn't fit? 3 great questions that Larry Wood taught me to ask of shock. Is it high cardiac output or low cardiac output shock? Is the heart too full or is the heart too empty? And the third question is, what doesn't fit? That's a lecture for another day, but I can tell you, if you take that orderly progression through working through a patient in extremis, always keeping in mind that something might not be quite right, you're going to use your system 2 effectively in context with system 1. In terms of inquiry and looking at accident investigations, I'll simply say we're bad at it. We're so bad because of our biases, and we don't recognize how difficult things are prospectively. Going back to my comment on cognition, I don't see a lot of study prospectively about how expert operators think. There's a lot of retrospective study, but in the medical field, we tend to always look at things through the lens of the retrospectoscope. And of course, it's within a milieu where the bigger the stakes are, the less we are able to acknowledge our biases and the more prone we are to follow them. So as a great example, we live in some sort of a complex world. All sorts of pathways could occur. We're trying to reconcile irreducible complexity. And then when an event occurs, suddenly it's very clear the pathway to the accident. This led to that, led to that, led to boom. And of course, if you take that and throw that into the complex world that we have, where we have all sorts of buffers, you probably recognize a Swiss cheese model on the upper left there, where an accident propagates through all of these different barriers. Between having a lack of knowledge of some of the latent failures in our world and the presence of hindsight bias, we get this idea that human error, so-called, caused an accident. And it's not really acknowledging the way we think. This talk is about thinking about thinking. This is thinking in retrospect. This is thinking not acknowledging all the complexities we deal with. Always go back and ask what doesn't fit. So how do we avoid our own biases? We can use formulas. So there's a very structured way to go through things. Checklists are cognitive artifacts that sometimes allow us to go systematically through and make sure we don't miss key details. Deep insight is hard to gain, but it is part of that expertise, and it's learning how to use your system 2 to think about your system 1. And then blinding, which is something we usually think about in research, right? We're trying to balance two groups in a clinical study. So one of the best ways we can do that, aside from randomization, is make sure that they're treated the same way. But we have to blind ourselves to our own biases. And working socially with one another, we have to blind ourselves to each other's biases, which means that we need a much better expression of what is going on in a group sense of meaning. Here's a very tangible way to think about thinking fast and thinking slow. Teach a central line to a trainee. So many steps, so many things going on. You have to get them all right. Some parts of the procedure are trickier than others. Remember the traffic grid? But what you want to do at the end is get somebody that's very reliable at producing a consistent product. So a trainee doesn't have muscle memory. They have task loading problems because they have to think deliberately with their system too about every single step in the procedure. At the same time, you don't have all day, and you have to perform this procedure safely. So one place for this is teach the person that there's a place to go fast and a place to go slow. What parts of this procedure are easy? We can rehearse those in advance, setting up the thing, moving your needle around, making sure that your wire's in the right spot. And then the slow spots as you are getting into the vessel, making sure that you hold the needle very carefully, that you thread the wire appropriately, that you check appropriately. Going fast, going slow is different than thinking fast, thinking slow, but it's a way to apply a useful construct to help save your cognitive resources. I said system 2 is capable of doubt because it can hold the counterfactual in comparison to what's going on. And so what that means is doubting is important. Thinking about what doesn't fit is important, as I mentioned, but it takes effort, and you have to spend your effort at the right times to do it. Sustaining doubt is harder work than sliding into certainty. So as a summary of what I've talked about today, breaking down fast, I'll point out that our high stakes environment means that we have to be able to move fast. We have to deal with trade-offs. We have to become efficient. It's critical to our operations. We need system 1 to survive. In terms of cognition, it allows us to get things done. Thinking about this social construct of error, it means that we frequently will indict system 1 because it's automatic, it's reflexive, it doesn't take into account the counterfactual, but it's also efficient. And we will say that that is the reason that someone would made a bad decision in retrospect based on the outcome, but without a real prospective understanding of thinking. In terms of communication, remember that what goes unsaid is as important as what goes said, but in expert environments, very little need be said. And there's a lot that goes into good communications, and I'll give you a few clues on that in a second. In terms of slow, in the high stakes environments, it's important to recognize aberrancies, and also that understanding risk takes effort. And you do have to slow down at just the right moment. It's like when you're driving your car and you know that you now have to pay a lot of attention. In terms of cognition, thinking slow trains our fast system. We use system 2 to get good with our system 1, and at the end of the day, they work great in harmony, building that robust expertise that we can't even describe adequately. In terms of error, it's the insight and the mathematical objectivity, the perspective that system 2 can bring to bear that allows us to actually think well about accidents and uncover all the multiple different ways that events can occur. In terms of communication, I said I'd tell you a little bit more about that, and this is the spot. Grice's maxim is a really nice way to think about communication. If you want to get at what is important in a handoff, or what is important in a sign out, or even talking about a patient on rounds, think about quantity, just enough, not too much, quality, relation, and manner. Those are the 4 things. And it's an interesting descriptor, again, a talk for another day. But to do this well, you need your system 2 to help you tease out all of these things. And then eventually you can train yourself to do it expertly, like system 1. Other things to think about with the slow system, math. You need to use system 2 for math. When you're thinking about how to set up your infusion, it's worth taking a step back and thinking very directly, very deliberately about it. It's really hard when the patient's crashing, but again, system 1 is bad at math. You want to be a healthy skeptic, you want to question your decisions, and you want to make sure you're always thinking about counterfactuals, other opportunities, or I should say other alternatives out there that might explain what's going on so that you don't go down the primrose path, because you will encounter fixation biases. You need system 2 for that. I already talked about training. To train system 1, you need system 2. Inquiry, as I said before, we think for a living. Being curious and really doing that deep thought is a great way to learn more and also to recognize your own bias. And so you need to beware of confidence. In terms of FAP, if you see math, slow down. In terms of skepticism, remember that your instincts are generally good. They have biases, but they're there to get you through the day, and they're right and helpful most of the time. And sometimes you just get that funny feeling about a situation. And it's worth looking into that, because your system one sometimes will trip you off as the first alarm in your monitor. In terms of training, you have to understand we don't always know why we're good, and a lot of experts can't explain why they're good. But as Larry Wood, another great mentor of mine, once said, some things are better caught than taught. And living in an environment like this is an expertise-rich environment where you can catch a lot of great things. In terms of inquiry, save the capacity for when it matters. Think deep, but you only get so much cognitive coin in the day. And then finally, try to avoid your biases. They can be harnessed for good. And a good example of that, like I said, is goal setting. Goal setting allows you to satisfy your system one. When you achieve your goal, you attach a positive thing to it, and it gets you through the day. And it also probably lets you think better in the long run. And with that, I would like to thank you very much for allowing me to come here today. It's really great standing in front of a live audience. I have to say, these events don't occur as much these days as they have before. And then I'd be happy to answer any questions.
So first, thank you, Mark, for that. As you talk about the sort of conflict of resources, cognitive resources, et cetera, to what extent do you think that technology can help us there? Our infusion pumps, you talk about math, but they basically do it for us. We have our electronic anesthesia record with decision support, et cetera. Can you sort of talk about where that should fit into this?
I love this topic, so thank you very much. And I'll send you a check later. That's a perfect question. The first thing I'll say is, I view technology as fundamentally neutral. In other words, it has as much potential to help as it does to harm. And let me try to give you some concrete examples of how that might be. I don't know if any of you have been on the electronic medical record when you get some sort of a pop-up that has nothing to do with the task you're trying to perform, asking you to do something and forcing you to click a bunch of buttons in order to get back to the task you were trying to do. That's an interruptive event that's built in to try to either help a clinician do the right thing or maybe to impose some sort of control from above. I view that as largely negative. It's cognitively disruptive. It slows people down, sometimes when they're most trying to be efficient. It's obviously there with some sort of positive meaning, but it is not a helpful thing. On the other hand, if you present in a data set, or say maybe like an order set, where you're ordering fluids for a patient, if the relevant information that you need to know to inform your decision making, like their last urine outputs, their creatinine, what their hemodynamics look like, and you can present that information in a useful way that can help inform a provider as a so-called cognitive aid, that's very beneficial. Infusion pumps are a really interesting example because when we really started developing infusion pump technology, we had a lot of confidence in the ability of the machine to reliably do the math, something that we know we're bad at in terms of thinking fast. And yet we still ran into problems. And a lot of those problems were related to problems of usability. The interfaces are not intuitive. That's an important term, intuitive. They appeal to system one. They actually, they fit in with how you think about the world. Or sometimes the devices can actually lead us down the primrose path. They make us think we're doing something that we're not actually doing. And an example of that would be mode error. You might be in a device where pushing a button in one mode does one thing, pushing a button in a different mode does another thing. So calculating an infusion based on a patient's weight versus calculating an infusion based on the volume of infusate going into the patient. If we think we're doing one, and we're actually doing the other, that's where we get into a serious misadventure. And so I think there's potential for technology to be very useful, especially in terms of data presentation. That's where you help cognition. I think that also, and frequently, unfortunately, in medical technology, there's this problem of cognitive disruption, and that's where technology actually leads us astray and sometimes makes our world more complicated. So it's a difficult question to answer. I think the potential is there, but I think it requires a lot of thought. And frankly, the kinds of studies that we've seen in other areas, but really haven't been well applied to medicine. Again, prospective discussions about how people think. Example would be, sit somebody in front of an infusion device, ask them to do some complicated tasks, then make it more difficult because you interrupt them with other tasks. See where their eyes are, ask them to think out loud. You'll learn a lot about what works and what doesn't work, but it's a hard thing to solve.
Thank you for very informative grand rounds. My name is Dr. Cesar Padilla, Division of Obstetric Anesthesia. I think as medicine moves towards the historical acknowledgement of racial and ethnic disparities, just give an example. Last week, we received an email from the dean that we're launching the Center of Health Equity. And certainly this movement is across the country. And our role as clinicians has been very well documented in sort of introducing bias. I think, an example that comes to mind is medical students from different backgrounds receiving different words to describe them, for example, based off their racial or ethnic background. How can we introduce tools and what strategies can we introduce to help reduce this bias that's rooted in social construct, some of the terminology you were using. So how can we introduce these strategies that disproportionately affect marginalized, students, communities, both in the education and clinical setting? Thank you.
So I'll try to approach that from a direction of equality and equity, because I think it's important to sort of looping it back around to cognition to think about sources. So we know that our environment is not even in terms of the backgrounds of different people that perform in that environment. And the racial and ethnic component of that is a very, very large backdrop. You're right, this is part of the social context. I would argue from the cognition standpoint, in thinking about this in terms of system 1 and system 2, what you need to understand is why is it that the mind of some people is coding particular information that should be irrelevant to the situation we're dealing with in a way that biases us in one direction. I would argue that probably first and foremost is that emotional component. There's some backdrop there where we are coding the way somebody looks, the way somebody talks, the way somebody performs or even identifies, and linking it to a natural bias in our minds. To break through that, there's obviously the skepticism and the doubt. System 2 can do that, but that requires people to acknowledge and dig into those things. The deeper issue, I think, is going back and figuring out why we are coding in our system 1 these sorts of biases. That's much more difficult, obviously, because it probably goes into issues of our childhood. It goes into the media we've been presented with. It's the way we were raised, the way we think about things. Very important problems. The best road I have seen so far, frankly, is open discussion. I mentioned in communication that it's often flagged as a problem because we don't always find ourselves on the same place, thinking about the same mental model of the world. And this is one excellent and large looming example of that. We may not all have the same perspective. We may be subject to biases, and we may even have different versions of the truth, such as it is, that are actually both viable, but we need to understand those differences and tease them out so that we can have a broader discussion. So in my mind, that's the first place. I don't think that's the end point, but a much more open discussion to try to facilitate a better model for everyone so that we're at least using consistent terminology or at least pursuing information in a similar way.
Hi, Mark. Good morning. Just two questions actually and a comment. And I just want to start by saying that interruptive BPAs, best practice advisory, which you just mentioned, as a medical informaticist, that just breaks my heart when I hear of somebody who got a BPA that has nothing to do with the task that they were supposed to be doing in the EMR. So if that happens to anybody in this department, I want to know about it because that's something that we really should manage. And we now added a button that says, was this BPA helpful? So if it wasn't, click on that because that actually gets review and it's good feedback. And sometimes we do retire BPAs that don't serve a good function. My question is, in a way, we're trying, as we understand the complexity of the data that is generated in high stakes environments like the ICU, we're trying to delegate some of these decisions to machines, trying to delegate it to maybe algorithms that can recognize patterns, that can recognize changes faster or maybe more subtle changes than we can. We know that some of these algorithms themselves have biases because they're trained on data that have inherent bias. But in a way, can you comment on the ethics of delegating some of these decisions to machines? And what does the future for that look like?
So I'll start with a disclaimer that I am not an expert ethicist by any stretch. So commenting on ethics, I have to be very, very careful. This is not my area of expertise. But I think there are a couple of interesting observations. As I mentioned before, I see utility in technology as a presentation platform. As a decision-making platform, there are a few concerns. I think there's a real potential, at least in what we have today, in raising alarms and raising awareness. An example would be these complicated artificial intelligence sepsis alerts. But I still see at this point technology having to be a partner with a human operator who is able to be skeptical, to think in detail, to entertain alternative diagnoses, and to not just be steered down the primrose path. It doesn't mean in the future we couldn't get to a point where technology could actually do some of our cognitive work. It does already, but it do it in a different way, like make expert diagnoses and true treatment decisions in real time. I see signals in the current world that make me a bit of a skeptic. And I'll give an example. There was an AI platform that was put together. It was looking, I think, at some sort of clinical outcome. And the idea was they let it have a go of all information in the electronic medical record to try to see which patients were going to do well and which patients weren't going to do well. And AI trains itself. So it's just pulling information and learning and learning and learning. But then when they went and looked under the hood, one of the things that seemed to strongly correlate with the model predicting a poor outcome was the presence of an R on the chest X-ray. And it was in an institution where the R was placed on the plate when the patient received a bedside chest X-ray rather than a chest X-ray in radiology. And you go back and you start to think about that a little bit. Why would the R? Well, sicker patients were in the ICU, they were getting bedside chest X-rays, and the model was cueing in on that as a very powerful signal. I'm not convinced that that reflects the kind of intelligence that we're ready to let loose on patients right now. Could we get there someday? Yes, maybe, but just being able to, think and say something's not right here. What is not going on? That still requires the human operator. And that's where I really believe right now the synergy is, finding ways to make technology as a partner rather than leaning on technology to make decisions. I like that all of us are smarter than any one of us, and creating an environment where people can share the information they have productively obviously breaks through some of these. It requires us to strip down some of the problematic areas in our social constructs, of course. But it's always the value to have the wise sage walk into a code, stand in the back corner with his arms folded, just watching things and just thinking about the counterfactual. It's really helpful. You had a question.
Hi, I'm Derelix. Thank you. And can you hear me? Okay. And I think I just want to emphasize the maybe and ask, how does this construct fit into the social constructs of how we function? And it may be touching a little bit on your comment that, the concepts of psychological safety, the dynamics of different people walking into the group. I mean, I think even the term you use, the wide sage, people bring into their mind a man instead of a woman. And I think that we often have an environment that sort of tilts things, as you mentioned, the bias. How do we function in a way to create that environment where we can actually do this sort of type 2 thinking, sort of in that sort of most effective way? How do we create that environment for everyone, not just ourselves?
This to me is a caught thought problem, a caught taught problem. In other words, I don't know a systematic way to teach that, except to immerse thoughtful, bright people that are being trained in environments where they can see it work. It is truly, I know it when I see it type of phenomenon. And I can think back to codes that went terribly wrong in my past, where there was a really bad social interaction. I can think about events that went incredibly well, where we had that sort of open discussion about what might be going on, and everyone got a say. We were able to prioritize information. I just gave it a short period of time, but those crisis maxims are really, really helpful when talking about how to relate with other people. But I think the other key thing that we have to confront with these problems is they tend to be high stress. There tend to be hierarchical structures. And that stress with those structures on top of what are usually pre-existing tensions within the system can lead to really problematic things. I mean, I can think of surgeons that I would, I'm not saying I'm never happy to have a code in my room, but I have surgeons that I'd be very, very happy to work with in a code. And there are surgeons that I know the second something goes wrong, it's only going to get worse. And a lot of that has to do with pre-existing social tension, which is also problematic.
I see no other questions.
I would like to thank you all again. It's been an absolute pleasure. Human beings, this is great.